mission and speciality, we always try to have a focus on inequality in all of the topics and fairness, obviously. So the title for this morning's topic is Addressing Health Inequalities Post-Pandemic. So I think you'll agree that it could hardly be more timely. We've three wonderful speakers to kick off the occasion, hopefully to stimulate questions and responses and debate from you. We're going to start off with Tim Collins. I'll introduce each of them more when we actually come to them, but Tim Collins will go first. He's the Chief Executive Officer of the Irish Heart Foundation. We'll then be followed by Avril Power, who is the Chief Executive Officer of the Irish Cancer Society. And then last but certainly not least, Joseph Musgrave, who is the Chief Executive Officer of Home and Community Care Ireland. So without further ado, as the cliche says, Tim, I'm really delighted that you have joined us this morning. I'm going to share the little details about you for the benefit of our online audience. You were appointed as Chief Executive Officer of the Foundation in August 2017. And you're a former GP. You were Chief Executive of News Talk. I was saying this to you earlier before we came on air. I don't know where you found the time to have this varied background in career. You were Chief Executive of News Talk radio station for 2 years from 2015 to 2017. And you were formerly Chief Executive of the Northwest Broadcasting from 2004 to 2015. From 1990 to 1997, you acted as Special Advisor to Government Ministers Mary Harney and Brendan Howlin at the Department of Health and the Department of the Environment. And you went on to become Director of Public Affairs with Drury Communications until 2003. And if that weren't enough, you qualified as a barrister in 2005 and in 1983 graduated in medicine from Trinity College here in Dublin. You completed your specialist postgraduate training in general practice before working as a GP in Ireland and Australia. During that period, you also served as Vice President of the Irish Medical Association. I'm exhausted just reading it, Tim, so congratulations. I'm certainly looking forward to hearing you. So the floor is yours, and I think you'll want to share some slides. So hopefully the technical department is well equipped for that. Go ahead, please, Tim. It's a pleasure to have you.
Thanks, Mike. My CV sounds like someone who could never make up their mind what they wanted to do in their lives. But I'm very happy in the job I currently have, and I'm just going to share some slides now. I think everyone can see that. For those of you who are not familiar with the Irish Heart Foundation, very simply, we're a community of people who fight to protect the cardiovascular health of everyone in Ireland. And our work breaks down into 4 broad areas: campaigning and advocacy to change public policy, innovating and leading in health promotion and prevention programs and campaigns, CPR training, and caring for people living with stroke and heart conditions. And in response to COVID and the sort of huge changes it forced on us as an organization, we developed a whole new strategy this year. And our key 3 strategic priorities in the strategy are addressing health inequality, addressing health literacy. And health literacy is interesting in that it is a key gateway to helping people to manage their own health and to change their health behavior, and then an ongoing commitment to innovation and research. So turning to heart disease and stroke, and I talk about heart disease and stroke and cardiovascular disease and kind of interchangeably, and they're broadly the same thing. But heart disease and stroke are Europe's #1 cause of death. About 9,000 people die every year in Ireland, and about 2 million people are living either with the long-term impacts of heart disease and stroke or the risk of getting them. And lest people believe that heart disease and stroke are diseases of old men, 1 in 4 people who have a stroke are under the age of 65, and heart disease kills more women than breast, cervical, and ovarian cancer combined. We know that adults in this country are at risk. We all can see that the figures, 60% of us are living with overweight and obesity. About 1.5 million people are living with risk of high blood pressure. And most of us are not getting the recommended daily amount of physical exercise. But more worryingly, children are increasingly at risk. about a quarter of all our children are living with overweight and obesity, and a portion of those now have high blood pressure at levels we've never seen before. And only a small number of primary and post-primary children are getting the recommended amount of daily physical activity. Safe Food Ireland produced a figure in the last couple of years, which we felt was really alarming. And that indicated that 85,000 of this generation of children, the current generation, will die prematurely due to overweight and obesity and the associated diseases from living with overweight and obesity. Turning then to health inequalities in Ireland, which I know we wanted to focus on today. The figures for health or for life expectancy are well known at this stage. People living in deprived areas, whether male or female, live a lot less than people who live in affluent areas. Healthy Ireland produce figures on a regular basis. They indicate that people are less likely to rate their health as good or very good if they live in a deprived area. They're more likely to have long-term health problems. People living in deprived areas are more likely to smoke. They're more likely to live with overweight and obesity, and they have lower levels of physical activity. And put simply, poor people get sick more often and die younger than wealthier people in Ireland. And then looking at cardiovascular disease and the impact of the COVID pandemic. In the area of cardiovascular disease, as by way of contrast with cancer, and Avril will be talking about this, I know, cancer and the whole area of cancer treatment is actually benefits from actually having a lot of data and very good data. But cardiovascular disease is the opposite end of the spectrum. We have very poor data in terms of the number of people who are living with conditions and the number of people who are even being treated. And it's a huge issue in the whole area of planning and treating cardiovascular disease. There's a couple of things we do know about COVID. We know that people with heart disease are at increased risk of death if they contract COVID. And very sadly, a large number of people who have died from COVID have comorbidities or have been living with, for instance, heart failure. And this has obviously been a lot of people in our community that we know and that we've been working with over the years. And then the other thing we know from COVID is that even people who have gone into hospital without a coexisting or pre-existing condition and with COVID have suffered then long-term heart damage. I've talked about the lack of data, but there's a couple of things we do know in terms of our services. We know that presentations for heart attack reduced during the pandemic, but life-threatening complications increased. We know that waiting lists grew, and that was down to the curtailment of services such as cardiac rehabilitation and heart failure clinics, where staff were actually moved onto the front line, and these clinics were slowed down or in some cases stopped. And the other interesting thing is that, you know, there was this narrative at the beginning of COVID that it was a great leveler, that everybody, you know, was equally exposed to this virus, no matter where they came from and what whether they're living in an affluent area or living in a disadvantaged area. But that's not the case. COVID has actually widened health inequalities because the incidence was higher in deprived areas, and it's impacted more on people living with chronic disease. And there are more people living with chronic disease in deprived areas. So it's actually worsened health inequalities. So where do we begin to tackle cardiovascular disease and health inequality? Well, the first thing we need to do is recognize that the health services are only just one factor, and we're all aware that the social determinants of health are probably much more powerful drivers of health inequality: poverty, social exclusion, poor housing, poor education, difficult employment circumstances, and so on. And they're probably bigger drivers, but I'm going to dwell on the sort of health services aspect for the next little while. So the first thing we believe is that we need a plan, and in the area of cardiovascular disease, we've lots of promises of plans, but nothing actually delivered. So there is currently a review of specialist cardiac services taking place that was stalled because of COVID. It's now back on track, and we're looking forward to that being completed. 4 years ago, we were promised a new stroke strategy. There is one. It's sitting on a shelf in the Department of Health. We need that to be published and funded. we need a new overarching cardiovascular health strategy. The last one ran to the end of 2019, and there's been nothing since then. That strategy, which was a 5-year strategy, has never even been evaluated. And then I've mentioned the dearth of data. We need all of this planning to be supported by a commitment to collecting real-time data. Apart from planning, though, I have a view about the next step. Yes, we need to tackle waiting lists, staff shortages, bed capacity, underfunding. But I think if COVID has taught us anything, is that big problems require new thinking. And the problems of waiting lists and staff shortages and bed capacity won't be solved with a few more beds or another waiting list initiative. We've known for decades that 80% of premature heart disease and stroke is preventable. And if we really want to tackle the toll of death and disability from cardiovascular disease, we need to focus more resources on helping people to live longer, healthier lives, rather than focusing almost exclusively on treating established disease as we currently do. And I want to focus for a couple of minutes on stroke as a kind of case study, because the absence of joined up thinking in our health service is typified by our approach to stroke. We currently have about 7,500 strokes per year occurring in Ireland. We think there's about 90,000 people living in the community with the impact of stroke, but be honest, we don't know because we've got no data. One of the interesting things, though, is that 80% of the direct cost of stroke is spent on nursing home care, while just 1% of the direct cost of stroke is spent on community rehabilitation programs, meaning we effectively wait until it's too late and then spend huge amounts of money on care rather than helping people to live independently at home in their own homes. And then we look at, even more worryingly, a combination of an aging population, which there's nothing we can do about, that's demographics, but worsening lifestyle risk factors such as the obesity crisis and the hypertension crisis. They're driving greater numbers, so that by 2030, we know that the number of strokes per year is going to rise to about 12,000 a year. So in our view, we clearly now need to focus on prevention. We need to stop this happening. We can't afford actually to treat 12,000 strokes per annum, and with all of the heartache that goes with that and the cost of the health services. And there's about 4 key areas we need to look at: overweight and obesity, smoking, air pollution, hypertension, and atrial fibrillation. And just turning briefly to a couple of these areas, just to remind you of what we need to do. Overweight and obesity is a major risk for hypertension and stroke. And yes, we need to help people to move to healthier diets and take more exercise. But the obesity epidemic has not been driven by a sudden generational loss in willpower. The much bigger drivers are actually environmental, and that's the ubiquity of calorie-rich cheap food, the relentless marketing of processed food that we have around us every day, a snack industry that just didn't exist 30 years ago and is now huge, the relentless targeting of children by junk food brands online, and then the completely inadequate and complicated labeling of foods, which makes it impossible for ordinary people to go into a supermarket and actually shop in a healthy fashion. And we know that if we fail to tackle all of these factors, that everything else we're doing in terms of all the money that's going to Healthy Ireland and all of the campaigns run by ourselves and other NGOs will be doomed to fail. So there is some light at the end of the tunnel. We campaigned long and hard prior to this current programme for government being drafted for a Public Health Obesity Act, and that is now in the programme for government. The problem is that it's been sitting there for 2 years and there's been no action. And we have been calling on the government to actually take this promise and make it a reality. And we believe that's the first step in tackling some of these really big drivers, which are policy issues rather than personal responsibility issues. So if we look then at, smoking. It's a major factor in many strokes. About 6,000 people still die annually from smoking every year. Teen smoking rates are increasing for the first time in decades, and there's been an explosion in vaping, which is targeted at children, and we know there's good evidence that it's a gateway to tobacco smoking. So we've been calling, along with the Cancer Society, and we've done a lot of work jointly in this area for new momentum in the Tobacco-Free Ireland policy. Tobacco-Free Ireland essentially commits us to getting to 5% smoking rates by 2025, and we're currently at about 15% on average. We're calling for significant price increases. It's currently about 15 euros for a pack of cigarettes. It needs to be at least 20. We need to increase the age of legal purchase of tobacco from 18 to 21. We need a full ban on e-cigarette advertising to everybody, and a ban on sale to under 18s, plus a ban on child-friendly flavors, all of that at a minimum. Turning then to air pollution. And this is something which we've been working on for the last while, because it is a major contributor to heart disease and stroke in this country. It costs about 1,500 lives every year. It's denoted by the WHO as the biggest environmental health risk in Europe, and as I say, a major cause of heart disease and stroke. Children, pregnant women, the elderly, and people living with pre-existing conditions are most at risk, and the mortality is highest in the most deprived areas where air quality is worst. People assume that Ireland doesn't have a major air quality issue since Mary Harney solved the problem in the 1990s, but that's not the case. WHO air quality guidelines were breached here at 33 sites across Ireland in 2019. Most of the health damage is done by PM 2.5 particles, and they're largely from domestic solid fuel burning. Again, there's some progress being made. The government have committed to new solid fuel regulations by 2022, and we need to hold them to their word. But we think we need to go beyond that. We need a new Clean Air Act that will bring our air quality standards in line with WHO standards. And we need to phase out the burning of solid fuel completely, not just smokeless fuel, but everything. And we need to also then address transport-related emissions. So then finally, hypertension. This is the single greatest health risk for stroke. The Lancet recently published a very interesting survey which actually highlighted that Ireland has one of the lowest rates of awareness, treatment and control of high blood pressure or hypertension among 12 high-income countries. 2/3 of people in Ireland, or 2/3 of over 50s have high blood pressure, and almost half of these are actually unaware that they have high blood pressure. The cost of doing nothing about hypertension is over 700 million to the health services, and that's not counting the lives lost and the heartache caused by the illnesses. And that's hypertension-related kidney disease, heart disease, stroke, and vascular dementia, and a range of other illnesses caused by hypertension. And just by way of contrast to that 700 million that it costs us every year to treat people with illnesses caused by hypertension, the Irish Heart Foundation proposed to Sláinte Care in the Department of Health about a year ago that we run a large-scale hypertension awareness and behaviour change campaign, modelled in a very successful Canadian campaign over 5 years in partnership with the College of General Practitioners, the Pharmacy Union, Tilda, and a number of other NGOs. And the objectives were very simple: to increase public awareness of the health impacts of untreated hypertension and to motivate people to get a blood pressure check. And the cost of that for a year would be 1 million per annum. And we're still waiting for an answer after months and months and months of negotiation. That's where we're putting our priorities right now. So in conclusion, I suppose a couple of points to make. The first one is that we need to get Sláinte Care back on track, and all parts of Sláinte Care, not just the reorganisation of the health services, but the entire report. And we need to place a new emphasis on prevention. We need to put tackling health inequality at the centre of health planning. And we need to tackle the vested interests. We need to get, for instance, IBEC out of the room. A lot of the decisions that impact on our health are made with, in consultation with industry and not with the NGOs that are actually there in the cause of the public interest. So those vested interests, whether they're marketing junk food or whether they're selling e-cigarettes or even coal, they need to get out of the room, and we need to make tough decisions to protect our nation's health. But I'll leave you with this one point. We shouldn't lose sight of the bigger picture. The biggest driver of global health inequality is climate change, and that threat is only beginning to impact. And next week is going to be the most important week, not just for the climate, but for health. Because if we don't take action, we are heading in a direction which is not just going to impact our climate, but our health in a very, very severe way. But if we get it right, we'll have less air pollution, we'll have more active transport, meaning people will take more exercise, we'll have healthier diets, we'll have less threat from infectious diseases and heat stress, and we'll have a healthier planet and a healthier population. So I think it's important that we don't lose sight of that as well. So thanks, Mike, for this opportunity, and I'll hand back over to you.
Thank you very much, Tim. That was really excellent. There's so much to take away from that. I'm sure our guests and those of us here in TASC will go through it in some detail. You've really given us a very, very informative and useful analysis, and pretty stark. I mean, I thought I was pretty unshockable about figures about smoking and cardiovascular and stroke and so on, but I realized, yeah, they are so shocking. Even I didn't realize they were so bad, and I have family history in relation to scars. I thought I was well on top of it. So thanks a million, Tim. Really appreciate it. Very much appreciate it. Our next contributor, I'm delighted to welcome Avril Power. Most of you, I think, know that Avril is the Chief Executive Officer of the Irish Cancer Society. And she has been Chief Executive since January of 2018. She has over 15 years of leadership, as many of us know, policy making and campaigns experience. And she served as Chief Executive Officer of the Asthma Society of Ireland. And she was a member of Shannon Éireann and a policy advisor to several government departments. Avril holds a degree in business, including non-profit management from Trinity College, another Trinity College grad here this morning, and was president of the Trinity Students' Union from 2001 to 2002. She also has a diploma in law from King's Inns. So some curriculum vitae to give additional weight and to what you're going to tell us this morning, Avril. We really look forward to it. I'll hand the floor over to you. Thank you very much. You're muted.
Thank you.
I'll now mute myself so I won't be interrupting you.
Thank you very much for that kind introduction. I have some slides to share as well, so hopefully that will work okay. Give me 1 second. Is that okay? You seeing my presentation okay? Yeah. Great, always good to check. So thank you so much for the opportunity to speak this morning about the impact that COVID-19, I think, and particularly the exacerbation that the pandemic has had on health inequalities, has had on patients with cancer and their families, and what we need to do to build back better.
Avril, sorry to interrupt there. The slides aren't up fully on the screen. It's just showing your desktop as well, just so you're aware.
Oh, really? Okay. Let me see how. Sorry, hang on 1 second. I'll stop sharing. No, wait, it is share screen. The application. Is that okay? Are you just getting the slides, or are you also still getting my screen?
We're getting the slides with your notes.
Okay.
So
if
you go to slideshow and from where you were, if you stay on that screen.
Hang on 1 second. Sorry about this.
You're fine.
So share this.
That's still your desktop view. Can you go back to the last view that you had?
Right, I'll stop sharing again. Yeah. I'm selecting a window, but it's giving you everything. Is it still, or are you just getting the slides?
Yeah, we're not seeing the full slide. I mean, if you want to stay there, but you'll have to scroll down a small bit.
Okay. So yeah. you were going to tell me, I think, how to share it properly.
Can you, if you want to go ahead with what you have up there, that's fine, but it's the desktop view.
Okay. Hang on one. It's a. I'll share. Hang on 1 second. Sorry, that is.
Yeah, you're grand. Take your time.
I'll share that's a PDF, so maybe that's the problem. But I have the PowerPoint version here. I'll just share the.
Lovely.
1 second. Sorry about this, guys.
No problem.
We okay?
Yep, that's perfect. And if you go to slideshow,
Yeah.
go to the tab that says slideshow.
Yeah.
And from the beginning.
Okay, I've done that. Is that okay?
Perfect. That's it now, Avril.
Lovely. I'm sorry about that. Okay.
That's okay. Yeah, all
I'll
done.
take that. I'll take that off my time.
Thanks very much.
So sorry, as I was saying, thank you so much for the opportunity to speak today about the impact that COVID-19 has had on people affected by cancer, and particularly the exacerbation that it's had on the existing health inequalities in Ireland. For those of you who don't know, the Irish Cancer Society is a community of survivors, families, patients, friends, nurses, doctors, scientists, professionals, supporters, and volunteers. We've all been affected by cancer, and we're all committed to helping to ensure that less people get cancer in Ireland and that as many people as possible survive and have a good quality of life after diagnosis. We do this by funding life-saving and life-changing research, by providing information, advice, and support, such as free nursing services, and advocating for systemic change. Patients and their families are at the heart of everything that we do, and it's that patient perspective that I'd like to share with you today. But I think firstly, I suppose, to understand the impact that COVID-19 has had on cancer care in Ireland, it's important to start by looking at where we were before the pandemic. And Ireland's cancer services, just like heart services that Tim has spoken about, faced big challenges even prior to COVID-19. There were big differences in survival rates, both between people with different types of cancer and people from different backgrounds. So I think one kind of really stark statistic that points that highlights that is the fact that the cancer death rate in Mulhuddard was 3 times that in neighbouring Castleknock. Really phenomenal statistic, and something that would be typical in disadvantaged communities right across this country. A lot of reasons for this. One is lower health literacy in disadvantaged areas, higher rates of smoking, lower uptake of screening, and reduced access to healthcare are just some of those reasons. An excessive waiting list for access to cancer tests through the public system is also another key one. And as many of you may know, with cancer, early detection is everything. Early detection can mean the difference between life and death. And Ireland has long struggled with access to diagnostics, and that has only got worse during the pandemic. Ireland also lagged behind other countries even prior to COVID in access to innovative treatments and therapies for cancer patients. And we had challenges, as you know, in attracting and retaining world-class healthcare professionals in our hospital system. So there were a lot of challenges even prior to COVID, but we were going in the right direction. 30 years ago, only 3 out of 10 Irish people survived a cancer diagnosis, and prior to COVID, we were at 6 out of 10. And with some cancers, the figure was closer to 90%, 9 out of 10 survival for prostate, for breast, and for testicular cancer. And this is thanks to incredible research breakthroughs like those made by researchers that we fund and those working in hospitals and universities across the country, improvements in service delivery like centralisation of cancer surgeries, and advances like the HPV vaccine meant that elimination of cervical cancer and other cancers was within our grasp. Unfortunately, COVID disrupted every single part of the cancer care continuum, from screening to diagnostics, treatment, and end-of-life care. Screening was paused in March 2020, and while cervical check and bowel screen started to resume in July and August, breast check didn't get back into operation until October. and taken together across those 3 programs, 250,000 people, 250,000 less people were screened in 2020 compared to 2019. And as you probably know, there's still a huge backlog in the screening services, particularly breast check. GP attendance has been down significantly throughout the pandemic. In our own survey research, 1/4 of people didn't attend their GP when they needed to, for a mixture of reasons. That there are always unfortunately, always issues around the cost of access to GPs, particularly for those who are just over the medical card threshold and can't afford to pay for their GP visits. That's an ongoing issue. But with COVID, we had the added issue of people not wanting to go because they didn't feel safe, felt that they were putting themselves at risk, or because they had difficulties accessing in-person GP services. And diagnostics were also disrupted. So even where patients have presented, people have presented with worrying cancer symptoms, where GPs have felt that they needed referrals, people have faced huge challenges in getting access to diagnostic tests. As a result of this, we're seeing a lot of later stage cancers now being diagnosed. So during the pandemic, we've seen there was a big drop, particularly last year, in cancer diagnosis, but of course, cancer hasn't gone away. It's just hiding behind the chaos caused by COVID-19 and caused by the cyber attack. And what that means is we're seeing some people coming forward now to be being diagnosed at a later stage, but we also know there's so many people in our communities, and particularly in our disadvantaged communities, who haven't come forward, people who have cancer today, who don't know that they have cancer, and won't be diagnosed until a later stage when their treatment options are reduced and much harsher treatment. And there's a reduction in their chances of survival and indeed quality of life after much harsher treatment. Cancer treatment was also disrupted by COVID-19, particularly surgeries, and particularly during those COVID surges every time. And I've heard the Minister talking about this morning in terms of the impact now on the fact that our COVID-19 numbers are back up at January levels in terms of new cases, and the impact that's having on the health service every time that more people end up in ICU with COVID-19. There's a knock-on impact on cancer surgeries and on other surgeries. And that's hugely distressing for families who may have already had their surgery postponed and now they're being postponed again. And it also affects their chances of survival and quality of life. Cancer research was also set back by the pandemic. For example, the number of patients recruited to cancer trials in the first 3 months of this year was down 45% on 2020. And that means we're depriving patients of access to potentially life-saving new treatments. So, I mean, the impact of all of this on patients and their families has just been immense. Cancer is awful at any time. It's awful to have to go through a cancer diagnosis, but going through cancer during COVID has just been horrific in terms of the levels of distress that it has caused people and disruption that it has caused to their treatment. You can see here some patient quotes on what that has looked like, including Elaine, who says that she was dropped, her husband Niall dropped her to the A&E at the hospital and waited in the car park thinking that he'd be brought home. Instead, she got a cancer diagnosis and was in hospital for 5 weeks without seeing him or her sons. And that's the harsh reality of what cancer patients have faced: the isolation, the distress, the impact that it's had on them and their families during the worst parts of COVID. At the Irish Cancer Society, we've tried to help as much as we could by expanding existing services like our support line so that patients can get access to free advice and support. We've pivoted our counselling services to a virtual service so that when people couldn't get counselling in person, that they could get counselling through a virtual service. We continued our volunteer driver service the whole way through the pandemic, providing PPE for our drivers and putting in place extra protections to make sure that we could safely bring patients to and from their chemotherapy appointments. We redeployed our Daffodil Centre nurses to work in the acute cancer units to try and help with some of the additional pressure there. And we continue to look after patients at end of life to our night nursing service And we worked hard as well advocating on behalf of cancer patients to try and reduce the worst impacts and try and get government to reduce the worst impacts on patients through public services. But there's no doubt, even with that Ireland now has, as a result of COVID-19 and in addition and the cyber attack, Ireland has a cancer crisis right now, and that the burden, unfortunately, as always, but even more now, is being disproportionately felt, as Tim said, by people from lower economic, social groups. We can't undo all the damage that COVID-19 has done, but we can mitigate the effects, and we can stop lives being needlessly lost through delayed diagnosis and backlog services. To do that, we need to increase screening capacity to clear the backlog. We need separate diagnostic centres so that people are guaranteed fast access and equal access to diagnostics so that we can catch their cancer as early as possible when it's easier to treat. We need dedicated cancer infrastructure so cancer services aren't competing with emergency care, whether that's COVID care, whether that's somebody's surgery being cancelled because of a car accident, whether it's the flu. We need to separate cancer services and other services so that patients are guaranteed that when they're scheduled for an operation that their medic believes is urgent, that they get it when they're needed and they don't have to, when they need it and they don't have to wait. And that means dedicated theatres and beds. We need to empower our healthcare professionals to come up with more effective local solutions, invest in research and trials, and improve access to innovative treatments. So I suppose finally, just to say, look, I know when we're looking at the impact that COVID-19 has had on cancer services and other parts of the health service, it can feel insurmountable. There's no doubt there are huge problems, there are huge inequalities, but we can get back on track and we can deliver a future where no one in Ireland dies from cancer. 30 years ago, cancer was almost always a death sentence. Today, thankfully, thanks to improvements in research and services, more people survive than don't. 18 months ago, I guess, when you look at COVID, the idea, we thought we'd be waiting years for a vaccine. And here we are now, with vast majority of Irish people vaccinated against COVID-19. And indeed, a lot of the scientific progress that has been made, particularly with the mRNA vaccines, is applicable to cancer and will help us save more lives and prevent more cancers in future. So with effort and innovation, we can not just overcome the current crisis, but we can build back better, and we can bring forward the day when nobody in Ireland dies from cancer and it becomes a manageable chronic illness, much like HIV is now. But we need much more investment, much more political commitment, and we also need a particular focus on addressing cancer inequalities so that everybody in Ireland benefits, regardless of who they are, where they live, what community they're from, or what their income level is. Thank you.
Thank you very much. Mute myself. Thank you very much, Avril. That's really comprehensive and very, very interesting. And I'm glad. It's always good to end on a hopeful and optimistic note, that despite the depth of the crisis that we're in, and despite the terrible history of the toll that cancers take in this society, that it is always better to advise people we can do this. We can actually aspire to a day when people don't die in this country from cancer. So thank you very much for that comprehensive presentation and hopeful analysis for looking forward. So thank you very much, April. So our final speaker this morning, colleagues, is Joseph Musgrave, who is the Chief Executive Officer, Home and Community Care Ireland. Joseph was appointed Chief Executive of HCCI in September of 2018, and he also serves on the board as a director on the board. Prior to that, he worked at a number of the world's leading communications consultancies. He has a significant experience with business operations, providing executive leadership in all aspects of communications. In one of his proudest achievements, which I was delighted to read, Joseph served as the national spokesperson for the successful pro-gay marriage campaign in the United Kingdom throughout its duration from 2012 to 2013. So I'm delighted to give you the floor, Joseph, and we look forward to what you have to say to us.
Thanks very much, Mike. I'm aware that you guys have been listening for 40 minutes to speakers, so I'm going to try and keep this relatively brief so we can get to some questions of yours. So just by way of background, HCCI, I don't have slides to share, by the way, so we can go straight to just right into it. So HCCI is the representative body for private home care providers in Ireland. And we've been in existence for a number of years. And as I said, as Mike said, I was the CEO since 2018. So really, just as a brief summary for those, I think we're all familiar with the concept of home care, but there's a line between home care and home health. And home care is things with helping with socialization, going for walks, getting your shopping done, groceries, tasks around the house, and medication reminders. It doesn't cross into providing medication, etc. And it's a key support to keep people at home for as long as possible, which we know is the state of preference. Over 95% of people is to age comfortably in their own home. Let's talk first COVID. This is where, despite huge operational challenges, the effect of COVID amongst our client base was a relatively positive story. As we know, around half of deaths from COVID came from nursing home settings in Ireland, and in other parts of the developed world, it was anywhere between 40 to 75% of deaths came from nursing homes. In Ireland, we never saw COVID cases rise above 1% of our client base of 20,000. Our peak number of cases was 195, and that was back in January, which is a huge testament to carers, but also to the resilience of the service. And we hope to capitalize on that success, because COVID has to be a moment for us to reflect on the model of care, the whole system. How do you care for people? How do you make sure that they stay healthy? And home care has proven to be one of the most resilient ways of caring for people. In terms of health inequalities within the service, one of the largest is between the urban and rural divide. It's a lot easier to care for people if you've got a row of houses that are densely packed. It's far easier to care for that in an urban setting. It's easier to schedule and easier to if you have a client who's gone to hospital, you've got to then put your worker, your healthcare worker to earn a wage somewhere else. It's far easier in an urban setting to do that. So one of our largest health inequalities in Ireland is an urban-rural divide, and we haven't really figured that out yet. I've been in this job for 3 years. I've had a number of proposals which have been looked at, and we can borrow from other models like Australia. They use a scale called the Monash scale, and depending how rural you are, they provide an extra payment to cover the fact that you've got to send someone usually out on a dedicated call to a particular region. There's also a problem in terms of access. As most of you know, Ireland is divided into 9 CHOs, 9 health regions. And the way you access home care is slightly different in each of those 9. So, if you've gotten home care for a parent in CHO 9, which is North Dublin, and then you've got a relative who's going through it in Galway, the process could look very different. So you don't actually have a uniform way of accessing the service. It's also fully funded by government. So even we don't really see a pattern of, poor people can access it as much as rich people because it's fully funded and assessed by the health service. There is a health literacy issue that comes in, and also an advocacy, how do you actually get to your package? But it's quite an opaque system, and that creates its own inequalities. Do I have the amount of hours I need, or does my relative have the amount of hours they need in order to stay healthy? And this comes back to one of Tim's points in terms of community rehab funding. If you look at that model, which he put nursing home care and then community rehab, if you flash up a different one, which is home care hours and then wraparound supports to actually state, as I stated what home care was for a reason, because there's a lot of things it isn't. It isn't rehabilitation in the home. It isn't home health. And so if you have someone who's deteriorating at home, in order to prevent them going into hospital, you need these wraparound supports. The system doesn't really do that very well. And this is where health literacy comes in, because how do you know what you don't know if you don't know it? And so what you find is a whole bunch of the client base doesn't quite understand, or they're not empowered to know what other supports should they have access to in order to stay home. And one of the things I want to flash up is back in 2008, the client base in home care was generally a someone in their mid-60s who would have home care for between 5 to 8 years before they might need to go to a nursing home. Now, the average person, fast forward just over a decade, and the average age of the person is closer to their early 80s. They get care for 1 to 2 years. It's become a palliative care service. It's no longer what it is, aging in place. You should support people from an earlier age so they don't become dependent. Our system doesn't do that right now. And it's something that needs to be tackled. There's also, I know this, I'm being creative here with the health inequality labels, an inequality in how home care is treated in the health service itself. The hospital discharge planning talks to the nursing home system, doesn't really talk to the home care system. Again, I've been in this job for 3 years and I've been trying to get home care at the table for discharge planning. How do you get someone out of hospital to home quickly? What's the impediment to that? Right now, there's not a person, I'm told by the HSE, waiting in this country to go from hospital to a nursing home. All the waiting lists are to go from the hospital into the home. And part of the exacerbation of that is a workforce strategy that's totally incoherent by government. Just as an example, in June, they announced that nursing homes and hospitals could hire workers from outside of Europe. And they said that home care couldn't, even though it's the same category of workers. So all you have is people in the country already who are from outside the EA, Brazil, the Philippines. All they've done is resign from home care and go to work in hospitals and nursing homes because they can resettle their families here and stay here permanently. So that is incoherent. However, the future course, as I'll try and wrap up as I take this brief tour through home care. The future for home care is all about the statutory home care scheme. As most of us know, nursing homes, there's the Fair Deal scheme where you can get access to nursing home funding for you or your family. There's no such scheme for home care. They've meant to put that in by the end of this year. That's been delayed by 2022. That's a golden chance, whether it's through the Statutory banner or whether it isn't. Frankly, I don't really care. All I care is that it happens and that it's a time to reimagine what you want home care to look like. I think it should be a service that cares for people from 18 up who need to age or be cared for in their own homes. It should cease being a palliative care service and it should move to being a wraparound community-based support service that prevents people from going into hospital, actually charts someone's frailties so you know if they need additional rehab support, because one of the primary drivers is someone gets frail, falls, and goes to the hospital. You've already missed the boat at that point. And that's why you need to move it to more of a community rehab model. And you've also got to empower clients. You've got to help and engage them around the health literacy piece, but also about what they can do for themselves in order to stop themselves declining as they age. So I'll stop there because we've only got 12 minutes or so for questions.
Thank you very much, Joseph. You certainly packed a lot in there. Thank you. That's really interesting. We do have, as Joseph says, some time for some questions, and some of you have already submitted questions. And as I mentioned earlier, we did have people contact us before we went on air, so to speak, with 1 or 2 questions. And so I'm just we won't have time, you'll appreciate, to get through all questions, but we will make sure that every question submitted is passed to our 3 panelists, and also will be circulated here amongst the researchers in TASC to see if any lessons can be learned or any benefits. I'm sure we get benefits from your insights, so appreciate that. I'm going to start off with a topic which is fairly topical and in the media a lot, and that's sláinte care. And we got a question in this morning which simply said, is sláinte care really advancing enough to become a reality? Very short and succinct, and I wonder if I'm easy as to who would like to go first. If you want me to be a dictator, I'd love to be a dictator. I'll tell you who's going first, but if I'm volunteering. So anyway, I'll suggest Joseph, if you'd like to say a few words in relation to that.
Sure. So I think partly sláinte care is doomed to failure at the start in terms of when Laura McGahey's office got part of the Department of Health and not the Taoiseach's office. That was a statement of how seriously this was being taken. And anyone who knows government knows that the Department of Health and the HSE have a very interesting relationship. And not to park sláinte care in the Taoiseach's office was, I think, a mistake. For home care's piece, the key part is the statutory home care scheme. Now, that seems to have quite widespread political support. And it's also, because there's no existing scheme, it's relatively easy, I say relatively easy, it's relatively straightforward to come up with a new scheme, to get legislation passed, to move it forward, and you can say, bum, 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 here's my Sláinte Care piece. It's far more difficult when you've got consultant contracts, and Avril was talking about potentially taking cancer services and making it more of a discrete service. Those things are much harder to do, because you've got existing health disruption. Then you've got to actually change the system whilst trying to care for people. So I'm much less optimistic about the wider structural changes of Sláinte Care, and I think the HSE can, rightly or wrongly, I think they could sit back a little bit and kind of say, look, we did a pretty good job during COVID, thank you very much. Please don't, come in and mess things up too much, because we kind of want to get on with the job.
Thank you very much, Joseph. Avril?
Yeah, I mean, I think unfortunately not. We know the waiting lists are now at record levels. That there is still, while there have been some improvements in diagnostics, and there were some improvements during the pandemic in GPs having greater access to diagnostics, we're still really far from where we need to be. We know that, as I said, people aren't going to their doctors. So I think the promise of Sláinte Care was incredible from a cancer perspective. The idea that everybody would have cheap and fast access to primary care, that you'd have improved diagnostics, and that from a cancer perspective, that would mean people being diagnosed much earlier when their cancer is easier to treat. So I think that the promise is everything that we would wish, like the same as the National Cancer Strategy, but I think delivery, unfortunately, hasn't matched up yet. And again, the greatest weight of that is being felt by people from disadvantaged communities. So for example, 1 in 4 cancers are diagnosed in emergency departments. And typically, again, those are people who couldn't afford to go to, maybe who had niggling symptoms but couldn't afford to go to the doctor, balancing competing financial pressures on their families, or people who couldn't pay for private cancer tests. So we haven't seen progress yet under Sláinte Care in tackling that. And hopefully maybe the fact that it's under the spotlight again after the recent exits, maybe we'll put political pressure on to make sure that it's actually delivered.
Very good. Thank you, Avril. Tim?
Look, I'd agree with Avril on that. I think we've no choice, though, to implement Sláinte Care. I mean, if you look at the basic principles behind Sláinte Care, it's about a greater focus on prevention. It's about a shift of emphasis onto sort of community-based and primary care services. It's about equal access. All of those principles are inescapable if we're to move beyond where we are at the moment. And I think that there actually is no choice. I think that we've lost a lot of momentum, and I think that's not surprising given the way that Sláinte Care was established within the department, and I'd agree on that point. But I think it has to get back on track, and I think that it needs a significant amount of political support now right across all of the parties to actually do that. If it's left to the government, I think that we're constantly victim in the health services with the tragedy of the horizon, which is you only address what is a problem today and you don't plan for the future. And Sláinte Care is about reshaping our health services. And we will never actually tackle waiting lists and tackle the enormous cost of hospital-based treatment and so on, unless we actually begin to address it through Sláinte Care and implementing those principles.
Thank you very much, Tim. I actually was unmuted, then I muted myself. Just shows you my familiarity with technology. And we had a number of questions, as I say, submitted earlier, and then some of the questions submitted today have centered around the whole idea of voluntarism and charitable organizations being involved in such a centrally important social area such as health and in all its dimensions. So I'm going to kind of make up a question myself, if you like, as a combination of those. I think it's fair to say that the questions coming in are related to, is it a good idea in itself that we have so many voluntary charity organizations? Should we be aspiring to a time when we don't need them? will it always be the case? And in relation to the funding, obviously all of us who depend on support from outside would hope that those who support us currently would continue to do so. But should we be advocating for a greater involvement by the state by supporting organizations such as yourself? So it gives you a pretty broad scope, but I think some of the questions coming in are focusing on this charity versus public service nexus, and interested to hear your views on it. So if you don't mind, I'm going to go to you first on that, April.
Thank you, Mike. Yeah, look, I mean, as I said earlier, the Irish Cancer Society's ambition is to make ourselves redundant, as I think any charities should be. We want to build a day where certainly in the first instance, nobody dies from cancer and it becomes a manageable chronic illness. And then ultimately a day when we learn more about prevention as well, as Tim spoke about from the heart context, where we're able to prevent more cancers. And with things like improvements in things like HPV vaccine and other vaccines that can prevent cancer in future. So certainly we'd love to have a day when we're not needed, and not needed to the extent, and cancer is not anywhere near the tragedy that it is today. I do think that charities have a role though in providing public services. You could say, people often say to me, so for example, we bring thousands of people, we brought 5,000 people to cancer appointments last year, giving them free lifts from their house to the hospital and back. Should the state pay for that? But then the feedback we get from those who use the service is it's a really special service. It's not the same as getting a taxi, someone who's paid to bring you there, being brought by a volunteer who most likely has had cancer themselves or a family member has, and that's why they've volunteered. They can provide a listening ear. They understand what you're going through if you want to talk. They understand if you don't want to talk because you feel sick after your chemo. So there are certain things you can't pay for. And I do think Ireland has this incredible ethos of volunteerism that's really to our credit, and you see the way that people stepped up, the charities stepped up, and our community stepped up and looked after the most vulnerable during COVID in a way that, again, I don't believe the state ever could, or any paid service could do with the same heart as much as the same efficiency. But there's no doubt, look, we would like more state support for what we do, and I suppose one of our ambitions as well is when we step in and fill a gap, and we start a service and we show that it works, we want the state to take it on and pay for it so that we can start something else and we can keep innovating and keep driving forward towards that day when nobody dies from cancer.
Thank you, Avril. Tim, you're muted. Tim, you're still muted.
Sorry. Unsurprisingly, I would say that there is a significant role for charities. I think that the sector makes itself indispensable through advocacy, through innovation and leading, doing all the things that government perhaps won't do because government is by nature cautious. And I think that it also needs to be pushed. So, an awful lot of the significant changes in public policy, and in fact, most of the big changes in public policy over the last generation have not been, instigated by government, but they've been as a result of pressure from, our sector primarily, but also other sectors actually going to government and saying, you need to do this, public policy needs to change. So I think that we play a very significant role there, not just in big public policy things, but also in terms of improving services. The other area where I think the sector is really important is innovating and leading. One of the things that we try and do, and Avril referenced this, is we try and identify where the sort of key blockages are, the key problems are. We try and come up with ways of solving them, putting in place programs that are evidence-based, and those programs tend to be pilots. We run them, and then we try and hand them over to the state to run. But I think that probably one of the biggest dilemmas that the whole sector has in relation to this is our relationship with the state. I mean, we're doing a lot of good work. We're constantly going to the HSE saying you need to fund us to do X, Y, and Z. And with that funding then comes a level of responsibility and a level of oversight. And we need to balance as a sector retaining our independence with very necessarily getting state funding for a lot of what we do, because a lot of what we do is, directly beneficial and directly in tune with what the policy of the Department of Health or the relevant department is. So that's a constant battle or a constant dilemma to try and figure out how do we maintain our independence. But I think that, you know, the sector has a very important role in our society, and I think that's going to continue.
Thank you, Tim. Joseph.
Yeah, look, at one level, I'm relatively agnostic as to sort of, you know, where the provision comes from. I think in reality, you got to look at outcomes first. So, you know, is the system as a whole delivering good outcomes? I think diversity is probably better than monoliths. And I think you generally see that in healthcare provision in places like Germany and Canada that have a slight diversity of provision. So whether it's volunteer, whether it's private, whether it's state, I think diversity is a good thing. I think there's a larger question then if you have diversity of provision, you have voluntaries involved and privates, etc. How does a patient access this panoply of different? Is it only people in the know that know, okay, if you go to that hospital that's done by that charity, you'll get better cancer outcomes than if you go to this one over there? Like, that's the sort of thing that I think is disempowering for people. In general, though, I think Tim and Avril made good points about there's a human element to some of what is provided, which is just inescapable and impossible to replicate. And I think the voluntaries do a good job of that. And again, whether it's a non-profit provider, whether it's a private provider, innovation is key. It's something that some parts of the HSE do well and many parts don't. It's not really part of their incentive structure to innovate. And so I think any conversation around diversity has to keep that front and center. How do you push on and improve the system rather than just tend to it as it is?
Thank you very much, Joseph. I've already said that we obviously have got more questions in than we could possibly deal with in this short space we have, and that included some questions sent in directly into TASC by people who didn't register to be with you. So I thought it might be useful to give the three of you a little bit of scope to concentrate on your own particular area. This one question might be useful, but I'm sorry, I'm going to have to ask you to be brief in relation to this one. But one of the questions which I think encompasses a lot of other subtext from other questions is, in the kind of medium term, say 10 years from now, where would you like to see your sector? You know, in terms of health, in terms of the cancer, heart disease, and aging. Just in 10 years' time, or 5 or 10 years' time, where would you like to see it? Tim, I'm going to start with you, poison chalice.
Well, I think it goes back to the points I was making in my presentation. I would like to see a huge level of focus and resources going into prevention. And I think that unless we do that, we're going to continue in the same merry-go-round of focusing on treating people with established disease. So I think prevention is something that I'd like to see a sea change on. And you know, the Healthy Ireland, which is the sort of prevention arm of the Department of Health, received, I think, a couple of years ago, their budget was 5 million. It's gone up to maybe 10 or 15 million right now in a sector which has a total budget of about 20 billion. So we have a long way to go there. I suppose if you ask me, there's probably two other things I'd like to see. I'd like to see social media regulated. I think that one of the biggest problems we have in terms of the food environment and the very toxic environment that a lot of our children are growing up in is as the influence of social media, and obviously it has a wider political influence as well. I think unless Facebook and other organizations are declared to be publishers and are regulated like every other publisher, I think we're going to continue to have that unhealthy influence on what we eat and what we do and so on. And I suppose the second thing then is that I would like to see COP26 actually taking action, because everything we need to do in terms of climate is going to actually improve our health, whether it's active transport, whether it's changing our diets, eating less meat and eating more fruit and vegetables, improving air pollution and so on. All of these things are the key things that we need to actually prevent cardiovascular disease. So I think next week is the beginning of the next 10 years. And I think if we get to 2030 and we've hit those emission targets, we'll have also hit our health targets.
Very good. Thank you, Tim. Joseph.
Yeah, I guess I would like to see a truly client-centered home care service that is one that empowers the individual to make choices around not just the home care hours and supports they need, but the wraparound supports that they have. I've been banging this drum for 3 years. I would like to get serious engagement around, really recognizing the home care workforce and changing that into an actual career structure. It's something that is often talked about, and I think that's one of the keys to really enabling the home care service and healthy aging to take off. I think I'll probably just leave it there because otherwise I'll go on. So I'll leave it those two things: client-centered home care service and a workforce that's truly recognized, and we actually chart out a career path for them.
Thank you very much, Joseph. Very succinctly put. Avril.
Well, we know that 40% of cancers are preventable, so I'd like to see us really realise the potential that that provides for us, and making sure that less people get cancer in the first place, so they never have to hear those awful words, "You've got cancer," or face into the challenges that cancer treatment presents. And then for those that do get the disease or want to move towards that day, as I said earlier, where it's a chronic manageable condition, and not something that is life-threatening or life-altering. And I think to do that, we need to make sure we need to build towards having equitable, clear and predictable pathways for everybody, from diagnostics the whole way through treatment and into survival, so that we can change, as I said earlier, and that we have as many people surviving cancer in Mudhuddart as we do in Castleknock. And where you come from no longer determines your cancer experience.
Excellent. I think it's a truism that in any discussion you can really guarantee that if the quality is good, the time will be efficient. So it is always, I think one's nightmare would be that you look at your watch and say, "Oh God, we've got another half an hour to fill. How are we going to do it?" Thank you very much. Such a challenging thing, and thank you for being so succinct. You really packed an awful lot of information into the hour that we had. And I just want to assure those of you who were kind enough and thoughtful enough to submit questions that we have all those questions. All those questions will be supplied to our three panelists, and also the questions and the comments will be studied by our team here in TASC. So I want to thank you all. If you don't mind, the usual thing, the kind of public sector announcements and the self-serving announcements from the organization now come in, just to remind you that we have a number of upcoming events. We're celebrating our 20th anniversary this year, and we have a special event on the 11th of November, Armistice Day, featuring Roddy Doyle and one or two other exciting guests who we're just not in a position to confirm yet. And that'll be on Eventbrite, but it'll also be a live event, and it'll also be live streamed on Facebook. On the 17th of November, on event, we have an international aid event featuring the CEOs of Concern, Trocra, and Oxfam. And that, as I say, will be streamed on in the format that you had this morning. And on the 22nd of November and the 7th of December, two other virtual events. We've returned to the series of conversations organized by TASC, conversations with business executives. And this time we'll feature Emily Pittman of Unilever Ireland. And on the 7th of December, one of the hallmarks, or one of the highlights, I should say, of our annual calendar in TASC is our annual lecture. And we're finalizing a very, very exciting speaker there. That'll be on the 7th of December. So before I thank all of you, and in particular Tim, Joseph, and Avril, and all of those who joined us online, and of course to my colleagues here in TASC who made the whole thing possible. And I'll just say, as my final word, we refer to the voluntary sector, we refer to the charity sector, we refer to the importance of it. Just to remind you, the TASC is one of those organizations that requires for its existence and the support of our friends. So any support you can give us, we would always appreciate it, deeply appreciate it, and need it. Thank you so much. I enjoyed it hugely. I hope you enjoyed it. And as I say, Tim, Joseph, Avril, I can't thank you enough. It was wonderful.